Welcome to the presentation regarding diabetes from Module 7 in Nursing 150. This slide is just a review of the mechanism of insulin and what it does in the body. It is secreted by the beta cells of the pancreas. The diagnosis of type 1 diabetes is given to those with the absence of insulin. It is thought to be an autoimmune disorder causing the absence of insulin. The autoimmune disorder causes a destruction of the beta cells. There's thought to be a genetic disposition to having this autoimmune disorder that causes diabetes type 1. There are two tables in your book that are comprehensive and talking about the difference between type 1 and type 2 diabetes. On page 1411, table 67.1, classification of diabetes mellitus. Also, there's a table on page 1417, table 67.4. It's a differentiation of type 1 and type 2 diabetes that can kind of help you understand the difference between the two types of diabetes. Diabetes type 1 absolutely requires insulin, that the patient receive insulin, since they do not have the ability to make insulin on their own because the beta cells of the pancreas have been destroyed by the autoimmune response. Diabetes type 2 is a diabetes that is thought to be related to the resistance of insulin that the body produces because of an continuous exposure of physical inactivity and obesity. These people do not necessarily need insulin provided for them. They basically need to attempt to change their lifestyle by losing weight, eating better, and becoming more active. Patients with diabetes type 2 typically have other risk factors and disease processes involved with the obesity. They typically have some cardiovascular diseases, some high lipids, high blood pressure, and increased clot formation. There's a section in your book that discusses metabolic syndrome. This is thought to lead to diabetes type 2 as well. It's kind of a new diagnosis in the past 10 or so years that they've been looking at as causes of diabetes type 2. The criteria for something called metabolic syndrome is an abdominal obesity, so it's a waist circumference of 40 inches for men, 35 inches for women. Hyperglycemia, so their fasting blood sugars are greater than 100. High blood pressure and high lipids. If they have that combination, they're thought to have a metabolic syndrome, which basically all of these leads to a patient having diabetes type 2. The most common lab test to diagnose a diabetes is a fasting blood sugar first, fasting blood glucose, and that is testing someone's blood sugar while they're fasting if they haven't eaten since midnight the night before, or at least in an 8-hour period. Glycosylated hemoglobin is an average blood sugar over a 90-day time frame. It's the amount of glucose that hemoglobin has binded with in the lifetime of a red blood cell, which is about 90 days. Criteria for diagnosis of type 2 diabetes, it can be found on page 1419. And that includes a hemoglobin A1C of 6.5 or higher. These are both blood tests, and they're pretty cheap and easy to run. These are the signs and symptoms of hyperglycemia. You need to be able to identify those. And in this case, if somebody's giving us these signs and symptoms, they're headachy, they're tired, dizzy, cramps, thirsty. Thirsty is one of the biggest ones. It's all the 3 Ps that are huge identifiers for a patient with high blood sugar, the polyuria, polydipsia, so that we can identify that their blood sugar is high. And the next thing you would do if you suspect their blood sugar is high is you can check their blood sugar if you have something close by that you can check it. So, signs and symptoms look like their blood sugar might be high, so we'll get a monitor and check it and see how high it is, and then we'll treat appropriately. For diabetes type 2, there are some medications that we could use to lower their blood sugar. Anti-diabetic drugs are based, the choice, what we choose is based on the patient's age a lot of times and their ability to manage multiple medications. Shorter acting drugs are typically given for older adults just because we can predict them a little bit better. Those with irregular eating schedules and those with liver, kidney, or cardiac function problems, they usually put them on shorter acting drugs. The longer acting drugs with once daily dosing are given to those who have a better adherence to their schedule. There is the risk that a patient, if they're uncontrolled diabetes type 2, may lead to insulin therapy in order to keep their blood sugar under control. Some anti-diabetic meds include the sulfonylurea meds. Sulfonylurea agents. They're typically, they work by triggering the release of insulin from the beta cells. Their side effects are many. They can cause some weight gain, and there's a lot of drug interactions with these kind of meds. Another common one that you might see is metformin, otherwise known as glucophage. And glucophage, we know, and metformin, we know you cannot take with somebody who has significant kidney function, and they have to make sure that they stop taking it prior to a contrast procedure or a procedure with contrast. Hyperglycemia is high blood glucose levels. It leads to fluid and electrolyte balances, and the big thing that it leads to is dehydration due to the polyuria. These are signs and symptoms of hypoglycemia. That's when the blood sugar gets too low. The patient will get very sweaty, hungry, confused. They can mimic the signs and symptoms of a stroke. So a lot of times if we fear somebody's having a stroke, we'll check their blood sugar to see if that's what it is or if it is indeed a stroke. There are several different reasons why someone gets hypoglycemic. Typically in an insulin-dependent diabetic, it's too much insulin related to their food intake and physical activity. They need to get things in balance a little bit more and decrease food intake. Maybe they took insulin and they didn't eat as much as they thought they were going to eat. So this is an emergency situation. As you have to keep your patient safe and make sure you get them treated appropriately because they can become unresponsive. So you want to make sure as long as they're able to take PO intake, you can give them some apple juice or some kind of a sweet to get their blood sugar up as soon as you can. If they are unresponsive, then you cannot give them anything PO, so it's going to have to be either a shot under the tongue of a glucagon or an IV push of some dextrose. So it's important to try to get something in somebody when you suspect that they're hypoglycemic and they're still awake for you. Complications of diabetes. For a patient with diabetes type 1, you have a diabetic ketoacidosis. It's called that because they have the risk of becoming acidotic due to the breakdown of fat. The diabetes type 1 patient will break down fat in the absence of insulin in order to provide energy for the body. And that breakdown of fat leaves the body with ketones, which an accumulation of ketones in the body will cause an acidosis, causes fruity breath, and it causes a patient to have Kussmaul respirations, which is rapid respirations because they're trying to correct their acidosis. Hyperglycemic hyperosmolar state, HHS, is what occurs in a diabetic type 2. That's a complication of it. When their blood sugar gets way too high, they become very, very, very dehydrated. These are non-compliant, typically patients or very sick patients that are not adhering to their diabetic regimen, and they're going through some kind of a stressful illness. That's typically when these complications occur. So it's kind of a picture of what a patient with diabetic ketoacidosis appears like. They have that fruity breath. tachycardia, low blood pressure, that signs and symptoms of acidosis, the Kussmaul respirations, they're thirsty, they're dehydrated. Their needs, hydration first, then insulin, then electrolyte replacement. These are the big signs and symptoms of DKA, which we kind of just went over: the dehydration, the electrolyte loss, polyuria, polyphagia, polydipsia, weight loss, vomiting, Kussmaul respirations. And we will hydrate them with fluid and go from there. Hyperglycemic hyperosmolar state. This is kind of a good visual of the vicious cycle that occurs. They have the continued urine output with the high blood sugars. So they're just severely dehydrated. The more urine they put out, the higher their blood sugars are. So, and there's no acidosis with this hyperglycemic hyperosmolar state. These are the signs and symptoms of profound hyperglycemia. And we're talking like upwards in somewhere of 800 to 2,000. Again, with this patient is a priority treatment of correcting the dehydration with IV fluids. After treatment with IV fluids, then soon after that, we'll get the fluids started, and then we'll start trying to manage the blood sugar. And they'll be on an insulin drip in an intensive care unit for this critical state. Again, those type 2 oral medications, first line of treatment for diabetes type 2 is initially a diet and exercise. And then always tell the patient when they begin on a type 2 oral medication, that they need to talk to their physician before taking over-the-counter medications, because a lot of these meds have a lot of contraindications when taking other medications, so they have some side effects. Anti-diabetic medication is not a substitute for dietary modifications and exercise. They should still do their diet modifications and exercise even though they're on the medication. And once again, metformin is harsh on the kidneys, so we need to avoid that in patients with kidney disease. And last but not least, I just want to mention insulin. We've talked about it in class, just want to make sure we are on the same page. The main thing with insulin is to know which is the long-acting, which is short, and to understand when these are used and how. The long is meant to be a basal kind of control, managed blood sugar. The short-acting is to kind of make sure that they get treated kind of quickly if they have more of an acute high blood sugar situation. And that concludes this presentation for diabetes for Module 7.